Hi, this is Allie Matejka with my Week 9 video for the class. Unfortunately, the semester is over at Heidelberg, so I've lost students who I usually use as volunteers, and my husband's also away recruiting this week, so I really didn't have anyone else to ask. So I'm going to try and play both roles here, but if anything's not clear, just please feel free to ask questions in the thread, but I'm going to try and do my best to explain as I go. So before we get into any of the progression exercises, we want to do a couple assessments. First would be the seated rotational assessment. So this is done with the patient's feet flat on the ground, legs together. You want them sitting up straight and their arms relaxed across their body. You want them to maintain a forward gaze, so we obviously don't want them bringing their head across the body with them as they rotate. So looking forward, sitting up straight, rotate all the way to the left, and that would be measured with a goniometer, and then all the way over to the right, measured with a goniometer. We're looking for the patient to have 30 degrees of movement bilaterally in order to make sure that they can do the next assessment, which are the rolling techniques. The rolling techniques, which I did a video on last class, we're looking for the patient to either lead with their right arm, supine to prone, prone to supine, left arm, same thing, and then with each leg, supine to prone, and then prone to supine. So those assessments are in the Hugenboom article that is available to us this week. And again, we're looking to use those assessments to see that the patient either has weight transferring issues, do they have stability issues, whether that's in the core. We are also looking to see if they use their head to help them rotate and things like that, just looking for the firing pattern. So based on those assessments would change how we move forward with the patient. So we're going to assume first off that the patient maybe had a lack of thoracic mobility due to the seated rotation test. So the first exercise we're going to do is actually going to look at increasing their thoracic mobility. Okay, so I'm going to show you two of the thoracic mobility exercises that I use. First one, very simple. I like to start with this one because it's a little bit easier, especially if someone is lacking a lot of thoracic mobility. So what you do is you have them side lying with their knees bent, so all the way down on their side. You're going to have them hands touching together, reach all the way back. This is better done on a table as well, because if they want to overhang the hand here, they can, and come all the way forward again. So here, opening up and reaching as far past their hand as they can. So this is going to isolate the thoracic spine and really help get some mobility there. So that's the first exercise I like to use. Another one, which is really common, we probably all used it or seen it before, is to have the patient on all fours. Make sure they're not sitting too far back, they're not leaning forward. Want them on all fours, down on one hand. I like to place the patient's hand on the small of their back and rotate this way. So I usually have them do maybe about 4 twists, 4 or 5 twists, and then I'll come in and actually hook my hand around their arm and actually help give them even more leverage there. So those are the two mobility exercises that I start with before getting into any more stabilization exercises. Alright, this next exercise is actually something that I learned as a little kid when I did gymnastics and have used for years, both as a coaching tool, and I've actually, excuse me, in the last few years incorporated it into my clinical practice as well, because I find that it's something really simple but can really demonstrate a good point to your patients, maybe even before you start using the roll technique. So this is a really, again, basic. You teach it to a little gymnast as they're learning to twist in their flips. So the easiest way I found to instruct older college-age athletes, so you have one arm up, you're making an L. And this is to teach them to incorporate their vision into assisting with rotation, which we've all read that research is very important to have the head lead the body in rolling assessment and rotation. So what you're going to do, hands in and out, I always tell my patients your nose or your chin should be right in line with your thumb. And what you're going to do is have them do the pattern of over to the hip. So it's very different. You can tell when I'm not using my head, I actually get different or less rotation than if I actually watch my thumb go all the way over. And I always, again, working with little gymnasts, I tell them you should be smelling your armpit. So we're following this pattern over, but you can really feel the difference when you watch your hand do this movement. It's really going to aid in the rotation. So that pattern is actually easier for me. I was a lefty gymnast, so you'll see the difference. I switch it over to the left. Again, initially, I'm not as comfortable with that movement. So to aid your patient, have them watch their thumb all the way over to their hip. And this really helps teach the upper extremity pattern of rotation and the importance of using your head to assist with that rotation. So ideally, the way I would progress that is to use, again, the rolling techniques that were provided for us in the article. To show the patient it's very important to have the head lead the body in rotation exercises, and that visual input is really going to change the dynamic of the exercise. So we could progress that simple gymnastics exercise into the rolling techniques to really enhance our patient's idea and understanding of using the head in movement. Okay, for my next exercise, sorry using the band here. Usually at work I would use the cable machine, but since I don't have access to the equipment this summer, first of all, I like to do rotation in a seated position to make sure that they have a good understanding before we change any base of support or center of gravity. So either with the cable machine or a band, I have my patients one hand, and again I advise them to watch the top of their thumb, make sure that they're not just externally rotating the shoulder, but that we're actually rotating the whole body. So have them watch the thumb, and then I tell them to look for the tip of their shoulder. So we're going to rotate, look for the tip of the shoulder or the fist out in front of them, following that thumb again. So seated rotation, again, very simple. The feet should be on the ground, very similar to the rotation seated test that we did. Then to change the stability of the exercise, change up the environment here, going to give them a Swiss medicine ball, and again, feet should still be on the ground. This is going to have them engage both the abdominals and the posterior core muscles more. So same position, watching the thumb over. It's just going to be more of a challenge to stabilize their body in this position with the ball, obviously. So again, make sure that their head is moving with the motion, because we want to increase and use that visual cueing there from the patient themselves. This can be changed up if we're ready to change the base of support. We can go into a kneeling position. That's really this leg board. So again, same thing. They're going to rotate, watching the fist, and this is a little trickier depending on if they're right or left foot dominant. Probably start with the dominant one while they get an idea for it. Whew. Alright, sorry about that. That's why I don't really like to use bands. But so after we are in the kneeling position, just on the flat surface, I don't have one with me, but I can either put an Airex foam pad underneath their knee. I can use a Dynadisc, depending on how they progress, to change the environment there. Obviously, that's going to create a more unstable environment. So definitely progress that way. When they're ready, start them or have them next progress to standing with a double leg position. Now I'm like afraid this band's going to hit me again, but and then still doing the same rotation. And then I like to go into a split stance. So not quite a lunge, but a split stance. One leg in front of the other and rotating that way. That's going to give them, again, a change in the base of support. Now that we're not double leg, they're going to feel a little less stable in the split stance. Again, we want to do that bilaterally, and you can change the environment by using AirX foam pads. You can change the environment by using Dynadiscs. Those are kind of two of my favorite that I like to use. So that's how I like to use the bands to progress through the rotation exercises there. Alright, so the last exercises that I usually throw into my rotational progression, which I can't do on myself, nor do I have a medicine ball here, but starting with a light medicine ball, you can do rotational catches across the body. So you would throw the ball to the patient and rotate. Obviously you don't want to start with too great of a weight to injure the back, but something that's going to give them a challenge. So you'll see I start in a double stance, standing up. You can even start in a kneeling position if that's more comfortable for the patient. And then again, I kind of just work my way up from there, very similar to the band. So it's a good progression for them to learn through. So lunging, changing that up, again, using an AirX foam pad, using a Dynadisc pad will definitely change the environment for them. And then you can stand and have them do a split stance, which starts to get really challenging based on their leg dominance. And again, using the different surfaces underneath the patient. So thanks for bearing with me being on my own. But if you have any questions on the exercises I did, or I know they weren't demonstrated the best that they could have been without a model. So just let me know if you have any questions, and I really look forward to your feedback. Thank you.